Well, good afternoon, everybody. I'm Holly, and most of you know me, but I see some faces and I have no clue who you are. So come introduce yourself afterwards because I hide up in the transplant office and I don't always get to see faces to go with new names. I'm going to warn you, you need to strap in and put your helmet on because this is going to be kind of fast and furious. It's a little bit hard to tell you what to do when people come in if I don't tell you a little bit about some of the nuances of the drugs and a little about our protocol and things like that. So it kind of made a very slide heavy presentation. So I'm not going to belabor every little point on the slides, and I'm not going to read them to you. So you have them at your disposal. You also have me at your disposal. So I'm going to try to speed through the not so important things to spend more time on the things that you're going to see the most. So pretty much what we're going to try to do today is review the protocol and kind of go over the whys and whatnots of what's on our transplant protocol. It kind of explain the importance of collaborating with both nephrology and surgery with these transplants and internal medicine or wherever they, or critical care or wherever they happen to be admitted, because different things need to be watched, changed, managed with a transplant patient, and evaluate dosing and route of administration and timing of the immunosuppression meds and levels and things like that. I'd say the biggest battle I have here is getting things given where they're not interacting with other things physically and or getting a level that's useful to me without maybe 3 tries. We're going to go over the different immunosuppression, kind of what our new transplant protocol looks like, talk about patients that are transplant patients, but maybe they're admitted for a different reason, and kind of how to manage it if you get a transplant patient, such as we had a few days ago. We got a liver that was transplanted in February in Pittsburgh, but he's here with a GI obstruction. So how to help surgery manage things like that. And we'll kind of gloss over a little bit on rejection treatments. This is here mostly for your information. I'm not going to give a huge lecture on the immune system. That would be a whole nother hour, but it gives you a little point in the immune system scheme where all these drugs tend to work. And our basic premise in the transplant world is attacking T cells mostly. And this is something I find kind of interesting. Even I find people in healthcare don't understand that a kidney transplant is put in a person's abdomen right up in front, and it's hooked in to the vena cava, and there's a little hole put into the bladder for the ureter to attach. So 99% of our transplant patients still have their other 2 kidneys. And something to think about when we're evaluating these transplant patients. The new ones say we do a living donor and it's a preemptive transplant, meaning they aren't quite on dialysis yet. Those other kidneys are still doing some work too, so you can't just say everything that's happening is due to the transplant. So, and some make urine, some don't, so it can really kind of cloud the issue. If I say you can tell the kidney's recovering when they're making urine, but they always made urine, it's not necessarily a fair statement. But most of our folks, you can kind of see a little pooch in their belly where the kidney is, and most of our people name it. So it's kind of fun. So our new transplants will either be from a deceased donor or a living donor. And the living donors are nice because they're coming, you can plan ahead, they're scheduled. It's really easy peasy in that regard. The deceased donors can come whenever we get a match, and they try to do the surgery before the kidney's been on ice for too long because that helps our outcomes. The big thing we need, from a patient when they come in to get a transplant, because some of our drugs are weight-based dosing, we hope that the nursing staff gets an accurate weight and height. And this will affect our thymoglobulin and to a point our tacrolimus dosing. Pretty much during the transplant process, we don't want any of our patients getting ACEs, ARBs, NSAIDs, and we will be holding anticoagulation. In the past, some of you guys that have been here for a while would have noticed maybe that we never did people on Plavix or Eliquis or anything like that. We have a new surgeon now. He's got an extensive history of doing liver transplants, which they don't have platelets and they bleed all over the place. And he just really doesn't care. So he'll operate on patients getting those drugs. So that can cause us some challenges later on, but we've not had any big issues yet just because of that. Clinical pharmacies always consulted on new transplants. That's because they are very complicated and things need to be started and stopped and watched and monitored and dosed. And on my end, a whole lot of pharmacy arranging and things like that. In the main pharmacy, you should be notified before you mix the thymoglobulin that the cross match is negative and the surgery is a go. If you get carried away and mix it ahead of time, you know, there's a lot of times you'll be throwing $6,000 or whatever it costs now worth of thymoglobulin in the garbage. They are supposed to notify you when it is a go. We have had a living donor that ended up with a bad cross match kind of late in the game. So I would still kind of be sure there's some communication going on before you mix that dose. Pre-op, they are to get the vascular skip protocol, which is typically ANSEF. Sometimes they will get vancomycin, and it's usually just the pre-op dose. And our induction immunosuppression includes our workhorse here, which is the antithymoglobulin rabbit. And we do have a couple of alternatives on our protocol. And I'm going to skip through them pretty fast because since Dr. Coco's been here, we have not used either one of the alternatives. He's pretty dogmatic about what he likes. So just for completion, I will mention Simulect or basiliximab. And it's a chimeric monoclonal antibody. We give a dose within 2 hours before surgery, and then 1 dose on post-op day 4. The nice thing about it, it's real easy peasy. It's a very short injection. It doesn't require pre-medications or any of the trouble that we typically have to do with the other agents, but it isn't as effective. So if we ever use it, the big key with it is being very aggressive with tacrolimus dosing post-op. All of these agents, we need to have the infusion reaction order set on profile so the nurses can access medications if they should encounter an infusion reaction. Some of the adverse reactions you'll see I have listed. These are more common too with this drug if they have ever received it before, say they are a second transplant or you're treating a rejection with it. But pretty much not big deals, just your typical reactions you would have with this sort of drug. Campath is a pretty popular in some other centers induction agent, alatuzumab. It's also used in some cancer therapies. Vanderbilt has been studying it for years. We've used it here 3 or 4 times before Dr. Coco came. And it too is a monoclonal antibody, and Vanderbilt kind of calls it bottled AIDS. It's very profound when you see the blood counts after they receive this agent of how drastic the white count especially decreases, and to the point where some of these folks require Neupogen to get a functional level back. So to me, that's kind of given another expensive drug to fight what the first expensive drug did. So the positives about it is another easy thing to give. You just mix it in a small amount of normal saline and you give it for 1 dose before the time of surgery. Once again, you do need the infusion reaction protocol available. It too, the provider must be in the REMS program for this drug, and it takes a little bit of talking, wheedling, sidewinding, and negotiations to get it if you're not a center that's already in their little clutch of people that use it. Another thing that kind of bugs me about this one is it does have a propensity to cause thyroid disease. So down to the one you're going to really see the most, thymoglobulin or anti-thymocyte globulin. There is a horse version. It's not preferred in transplant, but the rabbit is. So that's the one we have. And you'll often hear it called rabbit by people, and that's just easier to say than its true name, I suppose. The mechanism of action of this isn't thoroughly understood, but it does affect the T cell clearance from the circulation and modulation of the T cell activation. We give a pre-op dose before the kidney is perfused. Usually it's started in the holding area, but sometimes right at induction of anesthesia. And we give 3 total doses of 1.5 milligram per kilogram, generally at this center. I don't want you to nail me to the wall if you go somewhere else and they give 5 or 7. We used to give 5. Every center's different. Every doctor's different. This is kind of a very gray area of medicine because there's different schools of thought anywhere you talk to and look. So we've had pretty good success with the 3-dose regimen. I could argue if we had a high risk patient, it might be better to give another dose or 2. The big thing with this one, and this was also a big IV room money saver, is to pay attention to the labs before you mix it. If the white count's below 3,000 or the platelets are below 75, we need to be, once again, collaborating with our team. We need to talk to nephrology. A couple of the ways they might want to deal with this is maybe halving the dose and spreading it out over a larger number of days, or they might want to hold a dose. Some people want to just go ahead and push through and give it anyway. And while that all seems peculiar, I went to one conference and they said they gave all their thymoglobulin 3 doses, one right after another. And if the platelets were terrible at the end of it, it's like, oopsie, it just happens. So once again, it's everybody's judgment and experience and whatnot with this. So I can't really tell you how they're all going to behave. Usually Coco will give them half dose. Some of the other doctors want to push through, some want to hold it. So communication. Pre-medication is important. We give Tylenol and Benadryl before thymoglobulin. It's important to have the infusion reaction order set available, and that needs to be on profile for at least 6 hours after the last dose. And it is not real common that they have an infusion reaction, but we were treating a gentleman for rejection on 8th floor a couple months ago, and he did have an infusion reaction at the end of dose 3. We went ahead and finished it, but he had another one at dose 4 and we stopped it, and we wanted to give him 5. So it's not predictable like the first time you get it, you'll have an infusion reaction. It's not anything you can guess. If it's going to happen, it's going to happen. It is said that maybe people that are allergic to rabbits might have more of like a serum sickness from thymoglobulin, but not generally an anaphylaxis. But that's some of our people that just feel junky for a couple weeks after getting it, and then they start feeling better. We need to use a 0.22 micron filter. We give it here over 6 hours, and that is part of the reason we want to decrease the risk of the infusion reactions. If you look in the literature, you can give it over 4. if there's a reason to hurry it up, we could give it over 4, but we stretch our infusion length just to make it easier on the patient as far as the reactions. This is a huge question we get all the time. Thymo is not removed by dialysis. It's a big protein molecule. Dialysis isn't going to touch it. The issues with dialysis is nursing, monitoring, blood pressure, and what happens if they do have a infusion reaction. So depending if the patient's in the unit and they're kind of one-on-one nursing versus having to go to dialysis, it's very situational. Sometimes it's physician preference, but if you get an inkling that they do want to dialyze them, you might want to call before mixing it and see if that's the plan, and do they want it before or after, during, what time. So we have to do little tests because it's CE. So FT is a 56-year-old female, post-op day number 3 kidney transplant, had a dose of thymoglobulin due this AM. Which of the following would be an indication to reach out to nephrology to discuss potential modification of her regimen? Yay. So the new transplants, when they're admitted post-op, they used to be admitted to nephrology. Since Dr. Coffrin, and that's Alan Coffrin because there's 2 of them, his wife's here too. And Dr. Smith is still our backup. Their teams run the admission of the transplants now. Dr. Coffrin likes his residents to be involved in their care, so I do a lot of paging them through the surgery pager, because if you message the one that's written the note, usually they're off call by 7 o'clock and it's the wrong one to be talking to. So just find the pager number in their note and do that before you start epic messaging whoever. The nephrologist, if Coco's in, he's going to be seeing them, but I would just try to find the nephrologist that's in-house. There's only one now, I'm told, in Erlanger every day, and just have a conversation with them. If there's any issues you have questions about. We do DVT prophylaxis. Dietary's consulted because the dietary needs are very dynamic with transplant, especially with the electrolytes changing and things like that, depending on how fast the kidney's working. PT's consulted. We want them up and walking. We're consulted, and others will be as appropriate. Our post-transplant coordinator is Noelle Baldwin. She sits up next to me in clinic, if you've ever been up there. And she's kind of the bus driver of the post-transplant experience for these guys. So once again, another good resource. If you have an odd question about somebody, she might be able to tell you who best to discuss it with, or if you have some other question about aftercare. We do have a social worker involved pre and post transplant, and I won't even get into all those issues. And we have a financial coordinator. And I did want to kind of whip through the transplant order set. I just wanted to point out that we monitor extensive labs every day. There's quite a bit of electrolyte shifts. Once the kidney starts going, you'll really see. Typically, you see the phosphorus starting to go down. You'll see magnesium go away, and that's part of the side effects of our drugs, and then part the kidney working, and part just re-equilibrating the body to a different situation. We watch for bleeding, things like that. We watch ionized calcium. Typically, we order hydromorphone for 1 day and then hydrocodone, but we might switch that up based on allergies. We need to watch, morphine in our kidney failure people, but if they're needing pain meds and their kidney's starting to work, that could be something we could look at. We give a 1 single strength Bactrim every day for PJP prophylaxis. We give Zofran. We have some PRN blood pressure meds just to ward off evil spirits. We like to permit a little bit of hypertension. Usually, in the 150s isn't awful for our patients for a few days. The big deal with this is we want to be sure that kidney's getting plenty of blood pushed through it. It's had a bad day. It's been in a cooler, might have flown from California. You don't know. We just got to get the blood to the kidney to get it cleared out, get it working, get it awake, do all the things. So, if you were an internal medicine person looking at it and going, dear Lord, why aren't they doing anything? Well, that's kind of why. And then we start adding things in and try and getting it down after a couple days. We just try to keep them from having a stroke or whatnot, right there in the beginning. We have PRN laxatives. Sometimes this is some intervention you can do if they've not had a bowel movement in a couple days. Sometimes I have a little bit of a leash. I might order some Miralax daily and hold if loose stools under surgery's name or something like that. It's worse if they get too plugged up from the pain meds versus that, and that affects all sorts of things, including eating, med absorption, whatnot. And like I said, our pre-meds and our mycophenolate starts at 1,000 milligrams BID in the form of Cellcept. Tacrolimus, our standard dose is 2 milligrams twice a day. If I look at that, and I'll discuss that a little more, I might change the dose if they're a little heavier, and especially if they're African American. I'll be more aggressive because there's a genetic component that can make people of sub-Saharan African descent go through TAC like it's Tic Tacs. Anyway, an electrolyte protocol is very important because once again, our folks are cleaning house. That new kidney's getting in there. It's cleaning up all the toxins. It's getting rid of electrolytes. The meds have a great influence on that too. Our steroid tapers, 500 pre-op, 250 the next day, 125 the next day, and that's of Solumedrol, then 50 a pred, then 20 a pred. And then after that, we start, as appropriate, weaning off 5 milligrams a day of prednisone until they land at 5 and keep it there. We use Pepcid for GI prophylaxis, and it helps them tolerate the Cellcept in the first part of the transplant as well. If you've never really looked at the infusion reaction protocol, these are the meds that are included in it, and it's got when to and how to use it on the protocol. But if somebody's having, a little bit more of an infusion reaction before they can get the red coats or red shirts or whatever they call them here now, there to help with it. And usually ICU can manage their own issues, but they have these medicines available to help decrease the symptoms. And a lot of these meds can be restarted after a little bit of time at a slower rate after a mild infusion reaction. And the big exception would be the Simulect. Once they've had a reaction to that, we need to be done with it. All right, so sometimes our protocol has to change up a little bit. So we do PJP prophylaxis for 6 months post-transplant. And our favorite agent is the low-dose Bactrim once a day. Well, a lot of our folks are sulfa allergic, so then we would like to use Dapsone, and we will add a cephalosporin until the stent's removed, which is in about 2 or 3 weeks after transplant, just to help prevent UTIs. The Bactrim would do both. If they're allergic to Septra or Bactrim and have G6PD, we will use atovaquone. And I hear that stains white carpet very effectively, I've been advised. It's a nasty liquid and it's kind of, I don't know, some people don't mind it. Some people think it's the nastiest thing they've ever tasted. Cytomegalovirus is not our friend in transplant. We screen our recipients, we screen our donors for CMV, and based on their risk, we give them prophylaxis for it. If either one has been exposed, we will give Valsite, and we start with a generous renal reduction, and we'll increase it as renal function improves. I know literature says 900 a day. Dr. Coco 98% of the time prefers to just leave it at 450 a day, although if he's a little worried about somebody, we'll go on up to the 900 milligrams a day. Remember, especially with your technical staff and nursing, it requires safe handling precautions. I wouldn't put it in the pre-packer machines or be handling it barehanded. And big deal is it is teratogenic. If they are both negative, we will give valacyclovir or Valtrex or acyclovir for 3 months. And like I said, this surgical prophylaxis, we use the SCIP protocol vascular. The pre-op dose is sufficient, but once in a while we will get data from the donor of a deceased donor where they have had some sort of creature. And we will look at it and discuss it with surgery and Dr. or Coco and see if he wants to treat. Sometimes if they've had a staph or something ugly Kyle wouldn't want to mess with later, we will go ahead and treat them a few days while they're here just to be safe. GI prophylaxis. If I have a patient that's been on a PPI at home for a legit reason, I'll probably leave them on one here. They're not my favorite, but we do what we got to do. Or we will go to one if the Pepcid doesn't manage their symptoms, but we will try to start with Pepcid. As you guys know, the PPIs can cause issues with absorption of certain other meds and electrolytes. So I kind of care about the mycophenolate the most. Okay, patient case, allergy to Bactrim. Which of the following regimens is appropriate for antimicrobial prophylaxis? I should have done tongue twisters before this presentation. Any guesses? Yay. All righty. The one we love the most, tacrolimus, also known as FK506, Prograf, Astograft XL, but nobody uses that, but it might come up. And Envarsus XR, I'm using a fair bit of that. As you can see, the method of action, the initial dose in our center is 2 milligrams Q12. I might adjust it to the 0.0375 milligram per kilogram Q12 roughly if I need to go up based on patient's weight or ethnic makeup, sometimes age. The more you dose it, the more you kind of get a feel for how much people will need, but you know, I'd rather try to get them therapeutic while they're here than send them home with a level of 2 and hope for the best. If we have to give it IV, and I will make the big attention-getting statement that neither one of our physicians, surgery or nephrology, wants this to happen with reckless abandon at all, and they probably want to be informed, but this is something we do if there's no other recourse. There's an initial dose I have listed there, but typically what happens is it would be a person that comes in with some other surgical issue that they cannot take oral tacrolimus for a period of time. And that you would at least decrease it to the 1/3 of their oral dose and give it over a 24-hour infusion. Tacrolimus is nephrotoxic, which we'll mention in a minute. When you give it IV, that really compounds that tendency, so we have to be very careful. It does require a pharmacy consult when it's ordered, so somebody's bell will be rung when it is ordered. Your first job is to talk them out of it. If there's no talking out of it, then dose it appropriately, monitor it often. No PVC tubing. It can cause anaphylaxis along with killing kidneys. So we need to monitor the patient at least 30 minutes after starting the infusion and have the infusion reaction order set available to ward off evil spirits. When converting IV to PO, you would start the oral 8 to 12 hours after stopping the infusion. This is a handy dandy way to give TAC if you can't really use the gut. It's sublingual. It does require a reduced dose, typically 50%. And anytime you change routes of tacrolimus, that means you need to be doing some levels because you can't be sure that it'll be 50% and not 75 or something like that. So just a good place to start is 50% of your typical oral dose. Put it under the tongue and allow the contents to dissolve. And avoid swallowing, and I should have put the contents for 5 to 15 minutes. So the patient has to be awake enough or not awake enough, whatever, to hold that under their tongue for that period of time. And avoid oral intake for at least 15 minutes, and you can't suction them for 30 minutes. So it isn't going to be for everybody, but it's a great alternative if you can't give it through the gut. I do have a patient that came in from Duke that's a lung transplant, and she took it sublingual all the time. And I think the method to their madness was using less milligrams of TAC to get the job done with her. And she just did it every day, didn't complain. You can give it through the NG tube. You don't have to call Children's and order special potions. You just open the capsules, put it in some water, put it through the tube, make sure they're rinsing it out and flushing the tube. You need to give it consistently in regard to meals. Food does affect absorption, and the kind of food affects absorption. So just trying to be consistent with what you're eating. The big voodoo things to avoid are grapefruit juice, pomegranate, starfruit, several herbs, and we'll go over some of that again in a little bit, but there are food interactions similar to diltiazem, if that helps you cardiology-minded folks. Tacrolimus levels. If I had my way, it'd be perfect if it was 30 minutes prior to the AM dose. Close enough is good enough. You don't let them hold the dose. What lab does is they get all the TAC doses from Siskin, Memorial, all the Erlangers, and I don't know where else. They hold them till about 1 o'clock in the afternoon, and then they run the test. So you got to go ahead and give the dose or it'll be too late. The assay method or the lab used is not really significant with TAC. It is with cyclosporin and rapamycin. Usually the steady state for typical Prograf is 4 to 5 doses. We do levels with our new transplants every other day, which is kind of pushing it. You can get a little ahead of yourself, but like I said, we're trying to get them as close to where we want them as possible before we send them home. In Pharmacist XR, which is, like I said, an extended release form of Prograf or tacrolimus, it has a really long half-life. I really kind of like it for my patients that don't behave because it's got a lot of grace built in, but I never tell them that. You would monitor levels after you change the dose weekly because of this long half-life. If they forget a dose, don't tell any of my patients, but you've got about 15 hours to give the dose if they've missed it with Pharmacist, where you would have about 6 hours with Prograf. Remember with tacrolimus, especially with your heart patients, your electrolytes, it can increase blood sugars and affect QT prolongation. So if they're on a lot of things that do QT interval, you might want to think about that. The side effects we deal with a lot with Prograf, the ones we deal with the most are the blood sugars, electrolyte disturbances. I'm always giving people magnesium. It's unbelievable. We do have a lot of trouble with high potassiums as well, and especially if we want to give them other things, especially later on with, we want to give them a lisinopril or something, it can be troublesome. The Bactrim also increases K. We have a little bit of issues with that. Lipid changes, it can cause changes in blood pressure, blood counts. All of our drugs increase risk of infection, and the kind of sick twist to tacrolimus is it is nephrotoxic, and it can either be reversible or irreversible. If somebody's levels get a little high on me, sometimes you'll see their creatinine pop a little bit, but you fix the level, the creatinine will come back down. But if that doesn't get monitored and fixed, it can, over the long term, cause issue. Mycophenolate or Cellcept is the one we use here the most. There is myfortic or mycophenolic acid. These aren't interchangeable unless you do the dose conversions in your brain. 1,000 of Cellcept is 720 of myfortic. And that will become most important if you have somebody that you need to convert to the liquid Cellcept because they're on myfortic and they can't swallow pills anymore, something like that. Or if you're changing them to see if it might help with GI trouble. Myfortic's claim to fame is it is easier on the stomach. I think it may be. Dr. Coco's typical method of dealing with GI upset from Cellcept is to decrease the dose, and his concept is it's effectively doing the same thing as giving him a myfortic anyway. So I don't know, I'm kind of do what he wants and go from there. So we don't have so many people on myfortic, but like I said, Cellcept's the one we're using here. I've got it timed in Epic at 6 and 6, and that is mainly because it is physically incompatible with a whole lot of different electrolytes. And so the big ones would be calcium, magnesium, phosphorus, aluminum containing, magnesium containing acids, and or just think about what's in Nepro, what's in Ensure, you know, all those added minerals. So I would prefer them to try to take it on an empty stomach. If they are having trouble tolerating it, I'll generally tell them to take it with some crackers or toast or something that doesn't have all these additives in it to help them tolerate it. And that's something if you're staffing to think about if you're doing electrolyte protocol and it's the oral calcium thing that you give for 4 doses for 2 days, 4 doses a day for 2 days or something like that. Try to invent some kind of schedule where it's not within a couple hours of the CellCept. I think it's an hour before and 2 hours after. There is a nice oral solution of mycophenolate. You can give it via NG tube, or for people that have trouble swallowing. We've had that adventure this year. It's been a year of adventures. I had a patient, I had to give everything liquid. And the IV is very easy to give. This one I don't worry about at all if it needs to be given IV due to GI issues, and we do quite a bit. You typically give it over about 2 hours, and it can be peripheral or central. And there's not a big bunch of reports of infusion issues, or I can't think of a thing that I've heard come up with that. I would watch your IV compatibilities. Once again, I don't think I'd wire it into Ringer's lactate. As long as it's kind of a plain IV solution, it should be fine. Mycophenolate's adverse reactions. If I'm in clinic, the number one would be the GI upset, nausea, vomiting, diarrhea. So that's where we go into, helping our patients work through all that. And it can happen in the hospital as well. We can look at decreasing the dose. We can look at maybe, offering the toast or crackers with it. I hate doing it because it causes a whole bunch of drama, but you can split the doses up and give it over the same daily dose over 4 doses a day. My opinion is it kind of makes them sick all day instead of twice a day, but some people it works pretty good for. We watch our blood counts quite carefully with mycophenolate, and that's usually one of the first ones we decrease if we see some bone marrow suppression symptoms, leukopenia, thrombocytopenia. There's some other things listed here, and it gets kind of convoluted to me with transplant meds, as you see the same side effects for all of them. So you kind of have to, sometimes I wonder if they're just looking at all transplant patients, which one's really doing it. And it becomes a real puzzle sometimes. But mycophenolate, like I said, the GI symptoms and the blood counts are the real big ones we see. Also, we watch and counsel our patients to be especially careful with skin cancer and skin protection. And that's one of the main ones implicated with that as well. Black box warning. I tell all my old men not to get pregnant when taking CellCept, and it wakes them up from my teaching moments. If we do have a lady that wants to get pregnant, we do have to alter their med regimen in clinic, and it has to be all planned and everything. We counsel 2 separate methods of birth control if you are a reproductive age female capable of having children. The sad thing is it does interact with some oral contraceptives. PPIs can decrease the absorption. Don't ever crush, split, chew, stomp with a hammer, anything CellCept. There is a liquid. And we do need to be careful handling it, especially if you're a woman of childbearing potential. How's that for a word? Cyclosporin is an older drug. Back when dinosaurs roamed the earth and I was in Memphis, they did use this primarily because there wasn't tacrolimus. So it's another calcineurin inhibitor. It works a little bit differently than tacrolimus, so it has a little bit different side effect profile. There's 2 different forms of cyclosporin. There's Sandimmune, which is the old version, and there's the modified version, which is also known as Gengraf or Neoral. These aren't considered interchangeable, so as best you can when you're doing a med rec, if you can tell which one they're taking, I would leave them on the same form. Typically given twice a day, consistent with both time in regard to meals. Similar food interactions as tacrolimus. And similar side effects, though, where tacrolimus causes hair to fall out, we can grow hair with cyclosporin somewhere, sometimes not where you want it, but we can grow some. Hirsutism, gingival hyperplasia are more common with it. So anyway, IV, once again, same warnings as the IV TAC. Your first job as a pharmacist is to try to talk them out of it. Your second job is to be sure to dose it correctly, which would include at least a third of the oral dose. We're working with Epic. I thought it was built, but it's not, but I think it's sort of in there somewhere. But we're going to do a 2 to 6 hour infusion every 12 hours. No PVC tubing or bags, and we would obtain levels as a trough. And both with it and tacrolimus, it would be easier with this being a 12-hour infusion than the TAC is a continuous infusion, but you want to be sure if with the continuous infusion, you're getting your level from the opposite side of the patient as the infusion. And with this one, be sure if it's not the opposite side of the patient that they have flushed the line and things like that, so you don't scare yourself to death. Have the infusion reaction order set available. Once again, better safe than sorry. Sirolimus or Rapamune, I'm adding this for completion. We don't use that. Dr. Coco doesn't like it, so we don't use it much, but we do have some patients from our other nephrologists or that come in from other centers that are taking it. A lot of the rules with it are similar to TAC and cyclosporin. There is an oral solution, and I've got some comments there about that. You want to use precautions handling it. And the food interactions are similar. This one has a longer half-life, so you don't want to monitor levels every day. And even if you do, you're probably not going to get them back for several days from Erlanger. So it's sort of a long drawn-out process, but don't expect it back that afternoon. It's probably going to be 2 or 3 days. A thing to consider if you have surgery patients on sirolimus, it can delay wound healing, and that can be a problem. It's also has a lot of myelosuppression, malignancies, things like that. Zortress is similar to sirolimus. Dr. Coco favors it. We've maybe tried to use it one time, didn't work out. I'm just mentioning it because if it shows up again, you can go, oh yeah, that's a thing. One of the benefits maybe to using everolimus, there's an article and I have it listed here where they run both TAC and everolimus at 3 to 5, and it's kind of a drug sparing, kidney sparing sort of regimen that they're looking at. And it's the same drug that's used for cancer treatment under the name of Afinitor, but the dosing is different. And there is a suspension. Okay, for our center, I've listed all the drug levels we kind of look for. And I'll add a caveat that some patients are special and we run them a little differently, but you know, you won't get screamed at too much if you use this guide. At least you're in the ballpark. We don't typically check mycophenolate levels. We have a couple times in some really odd cases. We had a patient about a year ago, Bree surely remembers, that it was a GI nightmare, and we just wanted to see if she was actually absorbing it, but that's not really how we monitor the mycophenolate. Azathioprine or Imuran, that's an old drug used for a whole lot of different things. We would go to Imuran if the patient does not tolerate Cellcept or mycophenolate. And there are some patients that just don't. So we will give it a try with this one. Typically, we'll give it once a day. If in a bigger dose, we would do twice a day. It's recommended to give it with food, and there is an IV form available. The big thing with that is just watch your drug interactions and safe handling. Once again, typical same adverse effects as most of our other medications. I was in the shower this morning and I went, oh darn, I forgot Bella. So I added this slide real quick this morning. Aren't y'all happy? So Bella is an immunosuppression drug. It's a selective T-cell co-stimulation blocker. It is being used a whole lot at Emory because they are a study center for Bella. We have, I see some infusion center faces. We have a good number of people that get Bella infusions outpatient. It's rather expensive. The patient to get Bella has to be Epstein-Barr seropositive and TB negative. You have to register them with the New Logics distribution program. So if we get a transfer to care from Emory to us that wants to get their infusions here, I have to get their New Logics program number so we can get everything worked out. I put the dosing in. All that is very convenient and up to date. It's really a nice little protocol. If you're initiating it, it starts prior to transplant, and then frequently up until we get to the point where we go 5 milligrams per kilogram monthly, which is where most of our people are when we get them. I find it to be very well tolerated. There's not a whole lot of issues with it. It's really nice for patients that it's appropriate for. We know they're getting it. We don't sit in the office wondering if they're taking their tack on time or things like that. You know, I can tell when they've been to the infusion center and gotten it. It's nice that way. The big selling point for Bella is it's less nephrotoxic than TAC. The bad selling point for Bella is it's not as effective as TAC. What I learned when I went to conference is, you know, these centers that study these drugs learn how to make them work for them. And what they do is they give them TAC or sirolimus the first 6 months along with the Bella to avoid acute phase rejection. Then they wean it off. So if you get somebody that's on all the things, that's what's going on. And the other bad thing about Bella is it's more implicated with PTLD. So you're here and you're babysitting for me and you're wondering where in the world, what do I do with this patient? I've got to change their med action plan or something like that. So every patient gets a book and the cover of it looks like this. It comes in both English and Spanish. And it would typically be in their room in a carry bag that would either be typically blue or black, maybe red. But anyway, they will know where it is if you ask them where their transplant bag is. Inside this book, if they are ready for discharge, we will have made a med action plan. We have a nice little cool program that we can make them a menu of all their medicines and when to take them and how many pills. So say Bree's here on the weekend and she wants to change their TAC from 3 and 2 to 2 and 2. She can go up and make an X on the 3 and put a 2 on top of it and tell the patient, and it should work. At least that's what we hope happens. So anyway, they get this nice menu when they go home and in hopes that they'll look at it and take their meds correctly. So Jesse got to have the fun I let her kind of take over trying to figure out this liver patient that came in a couple days ago. So once in a while, we'll get a patient that comes in. Maybe they've had a car wreck. Maybe they have a GI obstruction. Maybe they have COVID. Maybe they have something else wrong, but they're a liver, lung, heart, kidney, KP, something from another center. And it gets really tricky. And I'll tell you right now, what the pharmacy says they're getting may not be what they're really doing at that point. So if you can talk to a family member, that's your best source of information, or that patient. If not, their center or a combination of both of them is your best sources of verifying the medications for these people. And, typically you'll find out that they do have an organ transplant. We found the information for this liver in Care Everywhere and Epic. We found, luckily, his Pittsburgh center was in Care Everywhere. So we flipped into that and we got his coordinator's number. So we called the coordinator and, we got the answers we needed. And it was pretty cool. They sent us a home med list the list they want him on, which may or may not match what the pharmacy last dispensed. If you have no information, I would go by the standard recommendations in a source like Up to Date or Micromedics for various organs. You're not going to go wrong. I will tell you, every center has different ranges and plans and thoughts and philosophies. But if you keep it in the range that's in that Up to Date online or something like that, where it's kind of a standardized data, you're not going to be total wrong. So take, for instance, this liver patient. He had a GI obstruction, so we couldn't give him oral medicine. So we had to change. Well, what we did was work with his center to see how they would like him managed. And what we ended up doing was increasing his CellCept and giving it IV. He was taking 500. We went to 1,000. He was on Rapamune. There was no reason to or way to give it to him, so we held it. Nice thing about Rapamune, really long half-life, so he was still kind of covered, and we gave him his steroids IV. And after a couple of days, he was able to go back on his oral meds, and I think he's going home today. If you've got a septic patient in ICU, a lot of times the first thing we'll do is want to decrease or hold the CellCept for a period of time. We've done that quite a bit with COVID patients, just to let their immune system recover enough to fight the infection. And that may be that we need to hold both the meds and just put them on stress dose steroids for a few days. So if you see a transplant and they're covered with a good hefty dose of steroids, don't have a panic attack because they're not on their immunosuppression. That's kind of probably what's going on. But I would watch them and make sure that, there is an adequate coverage, and talk to the players involved, be it nephrology, GI, their center, surgery. Also, when somebody comes in and they're getting a lot of different drugs for a lot of different reasons, if you're not familiar with them, run the drug interaction profile. Make sure if they're still on their immunosuppression, make sure that we haven't inadvertently given them something that's going to really wreak havoc with their levels and things like that. Also note that changes in oral intake, constipation, diarrhea, any big inflammatory condition, which I would include infectious diarrhea, COVID, things like that, TAC levels will jump way up. So you're going to have to be chasing that. If those of you that worked in critical care probably noticed that with the tacrolimus. So jumping right along here, next big pharmacy question. My patient has to go to dialysis. So I gave you a little list of our transplant meds of what's not removed in dialysis and what is. I will give you a caveat with thymoglobulin. If they choose to give the thymoglobulin before dialysis, they do need their steroid before the thymoglobulin, because we kind of use it for two reasons, both for immunosuppression and pre-med for the thymoglobulin. It'll remove 20-25% of the steroid. Depending on what's going on with the patient, it might not hurt to have a little booster dose after, but we haven't typically done that, and they've done okay. But as you can tell, most of the immunosuppression's not dialyzed, but the antibiotics are. And I'm not going to read all these out loud to you, but I will mention a couple of the most problematic drug interactions. I will tell you, I had a patient a few years ago that had a perforated ulcer. The notes from me and Dr. Coco saying do not use Biaxin was not read, and they gave her Biaxin. Her tacrolimus level was 7 on Friday. Guess what it was Monday? 50. Just remember, it, you know, after a couple of doses of Biaxin, it just went wild. Your azole antifungals, pretty bad interactions. Sometimes I give 0.5 milligram attack every other day with some of those. So anytime you get somebody sick with any of those types of things, please be vigilant and decrease the dose on the front end. There's no reason to give Biaxin for an ulcer. There's other regimens, but the azole antifungals are, if you need them, you've got to have them. Diltiazem, I've got a lot of people on diltiazem and TAC, but you just got to titrate the two together. If you start dilt, you got to understand you need to decrease your TAC and start over. All right, some of the anti-seizure drugs can be rather problematic. I had a guy get a transplant in Mexico on carbamazepine. We finally got him off that. But he was stabilized on it, but getting him off, we had to restart. Some of the antibiotics that you wouldn't think of, like nafcillin, and herbs is my number one question from clinic people, of what kind of thing can I take for pre-workout or to cure my blood sugar without insulin, or, you know. Remember, our kidney transplants, we're trying to avoid nephrotoxic things. Sometimes it can't be avoided, but just be really mindful of it all. And once again, I have a little list of my high potassium problems, but some of this can't be avoided either. I'll just say we use a fair amount of Lokelma. Statin drugs. It isn't that it increases the TAC, it increases the statin. So we start low and go up cautiously on our statins. Our favored one's pravastatin, just because it lacks those interactions so much. And our hope is that they're managed on that without having to go to a more high intensity thing that interacts. But if we do, we try to keep the doses lower as much as possible. The azathioprine, I think that should still be a board question on 9 million things that interact with that. So just be very careful if you get somebody on Imuran. All righty, you got a new onset seizure, and neurology's all crazy and come in and they want to order an anti-epileptic drug to treat it, which is not, or the least appropriate. All righty, Kyle's favorite, opportunistic infections. And I put my pretty zebras up here because I want you guys, when you get a transplant patient in and they don't seem normal as far as responding to antibiotics, please think of weird stuff. Please, please. They, because of their immunosuppression, are much more prone, particularly to pick up fungal infections and really strange things. CMV, we see a fair amount of it, can be very damaging to the kidney and very unpleasant for the patient. We typically use treatment doses of ganciclovir or valsite with them. The BK polyoma virus we monitor for continuously. Pretty much there's some drugs that have been studied for it, but pretty much the treatment for that is decreasing immunosuppression to help the body just fight it. PJP pneumonia. Like I said, histoplasmosis, toxoplasmosis, aspergillus, and candida are common. I'd say we see candida and histo the most. Herpes, that's all our favorites. Varicella zoster. I've seen 2 people come in clinic with chicken pox, guys. Like, whoever sees that? That's kind of spooky anyway. Hepatitis B, we try to make sure all our folks are vaccinated for that prior to transplant as an extra level of coverage. HIV, you can get it before transplant. You sure can get it after, and some of our people have it already, and we transplant them. Epstein-Barr virus, implicated with PTLD. And the problem too with a lot of this, and what makes it hard, is some of these infections can mimic rejection. So I have that listed, like the CMV and the BK particularly, and any kind of drugs that might have caused some kidney damage. And one of the things too we worry about, we've had a patient come in with an abscess in her kidney that developed a while after her transplant, which is causing problem, and the Epstein-Barr virus. All right, I'm almost done. Rejection, pretty much start over with induction agents. If we have no idea with some people, we'll usually blast them with steroids and get a biopsy, and then taper or adjust therapy based on what we find on the biopsy. The biopsy is the only way we can know what kind of rejection they have. And I've listed with the cellular rejection, we'll usually use the high dose steroids with 5 to 7 days of thymoglobulin. And sometimes we'll be a bit more aggressive with our TAC or mycophenolate. And we have to resume the prophylactic drugs if they get the thymoglobulin for the protocol timing. Antibody-mediated rejection, steroids, plasma exchange, IVIG, and rituximab, all are in some combination. Remember that plasma exchange will pull off rituximab, so it'd be preferred to do that after you go through the plasma exchange routine. And sometimes we'll get a mixture of both rejections, and they'll use a combination of the above 3 treatments. And, sometimes we can get them back, sometimes we can't, and it's sad when you can't. So, any questions? Bree's got one. I knew she did.
Can you, real quickly, so transplant obviously is highly regulated by CMS. Can you touch on the requirements that affect pharmacy specifically? No writing, post-transplant, those types of things, so everybody's aware of.
Yeah, that should have been a slide. CMS, new transplants note every day. Even though if you can put the sky is cloudy and it rained today, but put a note in every day. Usually there's something to say. I keep up with the number of doses of thymo they've gotten, kind of, is there anything odd, weird going on that I'm watching? if there's something I'm not hugely committed to, like may need to start blood pressure med in the next day or two or something like that, you know, your basic internal medicine / surgery sort of things that you would watch for along with the immunosuppression. If you have your TAC level report, you know, go through what the level was, what the dose is, what your plan is, what the range you want is. Transplants within a year, especially if they're within the next or within a few months of their original transplant, I still try to do a daily note just because they're still kind of in our realm. I would say maybe up into the first 6 months. And like I said, it doesn't have to be War and Peace, but just kind of that you're there and you're available and you're watching them. If they're further out, I do it more as an as needed basis. And a lot of times I'll do one just because I know them. If I need to point out certain things about that patient, I don't expect all of you guys to know them and do the same level of service. But like if I had one of my 3 years come in and I know this stuff is historically an issue with him, I might make those sorts of notes. But the big thing, if nobody's paying attention, you might want to monitor a level on what their immunosuppression is, be it TAC, cyclosporin, whatever. Often when they come in the ED, they'll grab a level and it's not even useful. It'll be at like 2 a.m. or 8 p.m. or right after they gave a dose, or you have no idea when they gave a dose, but it's some crazy funny time. The only thing that's going to tell you maybe is if they're toxic or not, but if they just took a dose, maybe not. And if it's non-existent in their body, you know they need some. So you might have to wait a day or so to get a steady state to be able to evaluate it. But if they drew one of those funny levels, please comment on it. You might not need to do a full note, but put TAC level of 23 taken right after dose given, not a trough or something like that, just so nobody looks at it and goes, oh dear, you know, TAC toxic, hold it, you know. If it seems peculiar, high, like I've had talked to folks and we've had one that it was drawn wrong, but you can still tell it's high. It's fair to hold the morning dose, get a random level and double check that and resume it in the evening. You know, better safe than sorry. Other CMS requirements, I have to write notes on all the eval patients and be involved in that process. I have to go to team meetings, be a part of that. So that's what I do kind of in my little castle on the hill up there. So, and then a lot of the management of them day to day, be it when we have clinic, we get levels, but we don't get the levels back for about 3 days. So we might see 40 people in clinic and then I get 40 charts on Monday morning for levels to go through and call people and try to get that sorted out and do dose adjustments and things like that. We also monitor electrolytes and vitamin D and cholesterol and potassium. Some of our folks, like I alluded to, have potassium issues and we have to manage that. Maybe they're having a lot of proteinuria and he's wanting him on lisinopril or something like that, or to push that. And we have to give them Localma to keep the K down so they can protect their kidney from the proteinuria. It gets to be kind of interesting juggling act. And then new diabetics, it's kind of interesting when you're educating them, especially post-transplant. A lot of diabetics are managed when they're on the machine getting dialysis and they're eating different and all the things. Their blood sugars aren't that horrible, Well, we give them a transplant, we give them steroids, we give them TAC. We stress them out a little bit, and all of a sudden, what was managed on little or nothing requires a whole bunch of insulin, or insulin when they've never had to take it before. So we end up having to juggle that around quite a bit until we get them tucked in with primary care or somebody else. But to be honest, we see them every week post-transplant for a month, so it's a little easier to do it through our clinic. Post-transplant patients, like I said, if you see something medically awry, I would contact either the surgery team or nephrology and at least ask them about it. You know, if you see a glaring thing that's missing, or, and that's one other thing I've neglected to mention. I look at their home med list. So if they're on an antidepressant, restart it. If they're on Synthroid, restart it. You know, maintenance meds that are important, with the exception of the blood pressure and ACEs and ARBs and things that we don't want to give a new transplant. But if they're on seizure meds, please restart them, you know, things like that. Oh, that's something that surgery probably wouldn't really concern themselves with as much. And I'm not being ugly. They just don't. They run their own show and they depend on us to remind them of those things. So, yeah, I know. Oh, I have a CE code, so you get credit from having to listen to me. ERL 22035. Thank you. 22035.
I think someone else has the room.
Okay. Thank you very much. And you can call and message me. It doesn't bother me.